The medical system is failing with osteoporosis. There are challenges with the drugs, there's issues with DEXA. All of those things add up, but nothing shows our failures as much as this article published in 2023. This article points out some clear issues in osteoporosis care that you can avoid if you know what they are. If you have osteoporosis, you're going to want to hear this. If you feel like the medical system has failed you in your diagnosis or lack thereof of osteoporosis, leave us a comment on YouTube. We'd love to hear about it. So most people here know that osteoporosis fractures pose a serious health risk to adults, potentially leading to debilitating and surprisingly high rates of fatal outcomes. I don't often like to talk about healthcare costs because the numbers get so big, they just seem so unrealistic. So this article also points out that the healthcare costs associated with osteoporosis are projected to go over $25 billion by 2025. This is in the US alone. The nice thing about pointing some of these things out, though, is that it catches the attention of some big players, particularly insurance companies, hospital systems, maybe some doctors. So some people are paying attention. Otherwise, things like this would get published, but it's not really enough to change practice yet, or at least that I can tell. So I want to show you how to avoid the shockingly common pitfalls pointed out in this article. But first, let me walk you through this publication. So this publication was a comprehensive retrospective analysis, meaning that it looked backwards in time. And it used both a commercial and Medicare database. So we're getting patients in both of the systems, if you will. The study focused on women aged 50 years and older that were diagnosed with a fragility fracture between January 2013 and June 2018. The data were evaluated for both inpatient, meaning in the hospital setting, and outpatient, meaning that they didn't go to the hospital. And patients were tracked for 12 months before and after their diagnosis. So what's the point of a study like this? Well, it's kind of like seeing how we did as a medical system or how we did as doctors. It helps us to look back and see what happened after someone received a diagnosis, or in this case, suffered a fragility fracture. So let's see how we did. Now, the study encompassed 108,965 patients, and they were diagnosed again with either a fragility fracture or a closed fracture, and this can definitely confuse things. And I'll talk about how these things are coded, which I had to do as a surgeon every day. There's some challenges with that. So the biggest point that the article wanted to talk about, again, was the cost of care. And so they talked about that 25 billion with a B. But specific to the patient, they were interested to look at what was the cost of care for each patient with their fracture for the subsequent 12 months. So this is kind of interesting. So the average annual healthcare cost for 12 months after a fracture was $44,000 per patient. And it's variable from kind of different situations. So there was an average of $71,000 for those that were diagnosed in the inpatient setting, meaning that they were in the hospital. The hospital costs themselves were also quite variable. So people that just went to the ER saw a bill of around $26,000. Yes, that's $26,000 to go to the ER. The highest cost, though, were people that were seen in urgent care, which is kind of interesting. So if you went through urgent care, the average cost was $147,000. I have no idea how that works out. So I often hear complaints about the expense of prevention, the expense of supplements, of good food, of memberships to my own program or other coaching programs or whatever. And I totally get it because resources are variable. And especially in today's times, resources are limited for a lot of people. So I totally understand that. But when we're considering where to allocate our resources, the cost of inaction really needs to be considered. Because go back and look at those numbers, 44,000 on average. 100 and something thousand, right? If you were to go through a certain pathway. If you had co-insurance, and a lot of insurances do, co-insurance of 10%, 20%, 50% can really sink, I would say, most people's finances, right? So then it changes the look of the cost of some things. But again, I get it that resources can be limited. So I'm not criticizing anybody, but just understand that the cost of inaction is real when you're dealing with something like a hip, spine, or other fracture. So before I get to the things that you absolutely should avoid, let's talk about some really scary findings that popped up in here. The first scary finding is that half of these patients were aged 50 to 64. And I hear all the time that people say, oh, I'm not going to worry about my osteoporosis because if I have a fracture, it'll be when I'm 90 years old and whatever. I think that's a bad idea anyway. But half of these fractures occurred before the age of 65. So that's a really big deal. What's even more concerning is that only 10% of these patients had a diagnosis of osteoporosis at the time. 10%. So that means 90% of these patients did not have a diagnosis of osteoporosis. And This isn't surprising. It's shocking, but not surprising, if that makes sense, because we don't start screening in the US until the age 65 for women and 70 for men. So they haven't been screened yet. So that's why they haven't had a diagnosis yet. And this just goes to show that that's why we should be screening earlier for sure. We'll talk about that later. What's also scary here is that the rate of subsequent fragility fracture was 26% overall over the next 12 months. So over a quarter of each of these patients that had a fracture suffered another fracture within the next 12 months. Talk about a lifestyle change. The most common fracture was actually not hip or spine. And you hear me talk about hip and spine all the time, right? But it's not just hip and spine. There's other fractures to consider. There's upper arm, there's pelvis, there's wrist. There's a lot of potential areas where you can suffer a fragility fracture from. Now, these statistics get really scary when you start talking about the inpatient setting, because these patients typically going to be sicker hip and spine fractures, but their subsequent fracture rate was almost a third, 33.2%. So how did the doctors do? Well, we already talked about the fact that 90% of these patients were undiagnosed. Is that really the doctor's fault? Kind of, because they should recognize that most of these people probably had at least one identifiable risk factor and therefore should have had early screening. But just take that for what it is. How did the doctors do with the diagnosis and with the treatment? All right. So about 20% of the patients that had these fractures were diagnosed with osteoporosis after the fracture. I'll say it again. These are patients that had a fragility fracture. So by definition, they already have osteoporosis. The diagnosis was only labeled to that patient or given to that patient 20% of the time. So now they're going to walk out of the hospital. They might not even know that they have a bone health problem, which is really concerning. And this was better in the inpatient setting, but still under 30%. So really not very good. Doctors are not doing a good job of actually diagnosing people with osteoporosis. Treatment was a whole nother thing, because you could argue, they say, well, we didn't diagnose them because they had a fragility fracture and we know they have osteoporosis, but we just went ahead and treated them. Well, if you look at treatment rates were abysmal in some settings. They were less than 10% in urgent care, and this is for osteoporosis, less than 10% in urgent care, around 10% in outpatient offices, around 11% in the ER. And when you get to the inpatient setting, then more people got osteoporosis management, and that was almost 30%. And us orthopedic surgeons were the lowest treatment at 11%. This isn't really surprising, because most doctors, again, don't want to manage osteoporosis. They'll diagnose a fracture. An orthopedic surgeon should diagnose a fracture and should treat a fracture. In my opinion, they should also have a fracture liaison service. They should manage osteoporosis as well, because most people don't have a place to go. But most clinics don't do that. So this just demonstrates between 10% and 27% of treatment for osteoporosis. So how were they treated? Well, as you can imagine, most people were treated with a bisphosphonate, particularly an oral bisphosphonate. These were drugs like Fosamax. This is not surprising, but it is concerning, because fractures don't heal well when you're on a bisphosphonate. And I know this very well as an orthopedic surgeon, that it slows down bone healing. Now, you could argue that the time to treatment was around 3 to 4 months. So maybe they intentionally let the fracture heal. That would be giving them the benefit of the doubt. My guess, though, is there was just that much delay in getting them into the office, the follow-up, and then actually starting treatment. In the urgent care setting, they were treated, if they were treated, in an average of about 6 weeks. So that is actually pretty close to when that fracture would be healing, and could potentially inhibit that fracture from healing completely. The patients that went on Prolia or denosumab, those patients were started treatment between 5 and 6 months. So again, maybe they intentionally let that fracture heal before they started treatment, which I would recommend that they do. So then they talk about screening, and they only get into sort of the traditional thoughts around screening, and they say how important screening is, but they don't get into what I think is really important, which is really urging early screening in specific populations, or most of the population, but specific populations. And I'm going to talk about that in just a minute. All right, so what are the big takeaways that you should take out of a study like this that's looking at how the medical system is managing osteoporosis? I think this study doesn't actually show the biggest problems. I think that this study is probably missing a lot of additionally undiagnosed injuries, meaning people that don't have a diagnosis of osteoporosis that have fractures. The coding around fractures is really difficult. So there's very specific coding around fragility fractures. It's different than other types of fractures. And with the new ICD-10 coding, there's so many different codes, and a lot of doctors aren't doing that correctly. So probably hard to know that they actually captured all the data to begin with. But the biggest issue I see is, well, there's probably 3. So big issue number 1, assuming that fractures only occur in the older population. 50% occurred in the age group of 50 to 64. So don't assume that your fracture is going to happen later in life, because half of these fractures happened in a relatively young postmenopausal population. Big issue number 2 is not anticipating the cost of a fracture, understanding the cost of inaction when it comes to not preventing that fracture in the first place, which in addition to the financial burden of, the cost of the fracture, there's also the burden of loss of independence or potentially death, right? Because we know 1/4 of hip fractures die within 12 months. Big issue number 3 is all of these patients have osteoporosis. Like I said, they've had a fragility fracture. All of them have osteoporosis. So why don't we give people a diagnosis of osteoporosis? Again, I think for the most part, it's because doctors don't want to manage it. They don't want to prescribe the drugs. They don't want to have the conversation, or they think they just don't need to, that somebody else is going to do it, right? The ER thinks that primary care will do it. The internist thinks that it's going to happen on the outpatient setting. There's not great communication from that perspective. So only 20% around on average were treated, and that is also a big issue. Now, I don't necessarily agree with how they were treating it, but if you have a tool, you should at least try to use the tool. And again, that 33% refracture rate, really concerning, and it likely has to do with the fact that not a lot of these patients were treated and not a lot of these patients were diagnosed. So I never want to disparage doctors. Doctors are doing the best they can with the tools that they have, and I totally get that. If we look at this from their perspective, some of these challenges are actually difficult and out of their hands. They're likely focused on treating the fracture. There's a lack of follow-up. A lot of times when a patient leaves the ER, they never go to the orthopedist. They never go to their primary care doc. They never follow up again. Happens all the time. There's a lack of priority when it comes to medical management. Maybe somebody had a lot of other issues and they didn't want to add another drug. Maybe there's just a lack of interest in the patients. The people that are watching this channel are very proactive. They're very interested in their care. I can tell you by working in some of the traditional medical systems, especially trauma centers, a lot of patients aren't looking to improve their health. They're just barely getting by, and they're not interested in what you have to say about lifestyle, about supplements. They don't care about any of that. They just want the surgery or the drug that's going to get them feeling better. And that's a big challenge, because doctors get stuck in this mindset that that's all they have to offer, when really you are a testament. Anybody watching this is a testament that there is a large population of people that actually want to take control of their health. And that brings me to my biggest concern and my biggest issue of things that you want to avoid that are brought up in this article, which is the lack of responsibility. You have to, as a consumer of healthcare, take control and responsibility for your health. You cannot rely on our medical system to give you what you need, especially if your goal is to do things naturally, to do things without drugs, to do things without surgery. You have to hop on it. You have to be aggressive. You have to be proactive. You have to do your own research. But you already know that, because that's why you're here. Now, if you're having a hard time putting all that together, remember that our Bone Health Masterclass is here for you, totally free. Look for the link in the description on YouTube, or go to optimalhumanhealth.com if you're listening to this on a podcast. And you can sign up for our free masterclass where we talk about how to put all these things together. And then we leave some time for Q&A. And I run those myself. I run them live, and now we're running them every week. So this video was a review of the failure of the medical system for osteoporosis. If you like this, you might want to consider the Diet for Osteoporosis in 2024 video, or Exercise for Osteoporosis, which was also updated in 24. So remember that osteoporosis isn't the end, but deciding to reverse it is a beginning.